look at the factors that are mainly recognized by the international scientific data to be the most promising one, the fetal fibronectin and the short cervix, evaluated by ultrasound cervicometry. There was a very recent paper on the health technical assessment in which you see the likelihood ratio of using the measurement cervical length with a cutoff of 50 millimeter and using the fetal fibronectin, positive or negative, are the best predictor for spontaneous preterm delivery within 7 days in a patient with the symptoms. So, even though we have different markers, I think these two are probably the best. I don't enter in detail how to measure the cervical shortening, but it is quite clear that a cervix less than 1.5 centimeter is probably a cervix which is indicating high risk of impending labor, or at least a labor going on, while if the cervix is more than 2.5 centimeter, probably is not true labor. And if we use biochemical markers, you see fibronectin looks as the best negative predictive value. Although we may have a marker like interleukin 6, which was mentioned also today, but in amniotic fluid we may have a very high positive predictive value. Altogether, this is very difficult to use because you need to do an amniocentesis, and I don't know, many of you are keen to do an amniocentesis in a patient which is having pain and laboring preterm, and of course there is much better to do a test in cervical or vaginal fluid. This is just to show the very last data we did in a multi-center trial in Italy, which I coordinate, in which we use the fetal fibronectin test result as positive or negative, and in combination with the ultrasound cervicometry, taking the cutoff 2.5 and admitting or not admitting the patient and treating the patient according to the different results. We had 132 cases evaluated by fetal fibronectin, 96 cases evaluated by cervicometry, 64 were combined. The mean gestational age is 30, you see, only 18% have preterm delivery, and these are the data by autocolysis. And of course, vaginal delivery happens to be 92% of cases. Not too much, slightly more male, as I said this morning, than female in this case. And you can see that the fetal fibronectin was positive in 34 cases, while cervicometry was less than 2.5 in 54% of cases. So the final data, putting all together and looking also the concordant result between the two, were that if you look at the sensitivity of fibronectin and the predictive value, we have very high good predictive value by fibronectin itself, and reaching 99% as negative one. So if a patient has a negative test, there is only 1% of chance she will deliver in one, unless we take the cutoff point as 34 weeks of gestation. 34 weeks. Whatever was the entrance gestational age, 34 weeks. And if we combine with cervicometry, we reach 100% of negative predictive value. But by itself, the cervicometry test, so the 2.5 cutoff of used by cervicometry is giving 95% of negative predictive value. We had also used another test in a different study, the IGF binding protein 1, which is a trade name of actin partus, which is another similar protein to fibronectin. And we include 80 patients in one, and we evaluated 68 because some of them were also positive for PROM test. In these 58 get cervicometry. You see 11% had a preterm delivery within 34 weeks, but the result itself of the partus alone is 89%. Cervicometry test is 86. If I combine the two, I go to 97%. Not as better as fibronectin. So in any case, I believe the combination, and this is the message you can have also from this small but significant study, because it was conducted in a prospective way, is that the fetal fibronectin plus cervicometry is giving the best negative predictive value. So it avoids the patient to be admitted in the hospital, it avoids therapy, it avoids anxiety from both sides. But we also have established that using the other test is at least less predictive. And we avoid in 75% to give any therapy to this patient. This is particularly important because in this study we had 100 people, let's say 100, which came to the hospital claiming to have pain in early gestational ages. Of these people, only 25 received some kind of drugs, according to the fact that we were able to establish much better than just by looking at the contraction and a cervical evaluation, but with the cervicometry by ultrasound and fibronectin, that they were appropriate to give them some drugs. I want also to show you that if we use appropriately this test, like fibronectin, we may avoid also a lot of corticosteroid treatment, preventive treatment for respiratory distress syndrome. You see in this case that if we have no test, probably I need to treat 100 patients before 32 weeks to avoid one case of respiratory distress syndrome. If I use the test of fibronectin and this is positive, I will probably treat 17 patients and I get one better outcome. But if I treat and the test is negative, I need to treat 500 patients to see any result. Now, consider that corticosteroids are not easy drugs, are powerful weapons in our hands, are given in very high dosage, so we have to be very careful to give these drugs, and the best way is to select appropriately patient. And these are the suggestions that the guidelines, the European guidelines gives, that we may use nowadays transvaginal ultrasound because they have better sensitivity to evaluate the cervix, and oncofetal fibronectin should be added to the clinical assessment. And I believe that as a message that you can receive nowadays in patients which have some symptoms, the best is to combine the cutoff 2.5 and negative fibronectin to exclude the labor, and to have the cutoff of 1.5 and positive fibronectin to admit the patient. In between, there are still controversies, but I think that cautiously it depends also from the gestational age you are admitting the patient. Because if you have a 2.5 centimeter with positive fibronectin at 28 weeks or 26 weeks, it's better to admit to the hospital, at least to look at the patient for some days. So nowadays, along with the symptoms and the recognition of specific risk factors, we have these two that make the diagnosis more accurate. And it has been demonstrated that they decrease the cost associated with hospital admission and provide assurance to women and families, avoiding a lot of transfer. Now, the second point is the appropriate tocolysis. And in fact, I was saying, what we are using tocolysis drug for? You know, primary aims are only two, really, because either we use the tocolysis to give time to, administer glucocorticosteroids in order to avoid either respiratory distress syndrome, either in some cases intraventricular hemorrhage, or to arrange in utero transfer to a hospital with a neonatal intensive care unit. The secondary aim, which is maintained only in the tertiary center, is that continued tocolysis may be needed in some cases in order to, allow a gaining of days in utero in order to improve the mortality or decrease the morbidity of a specific patient. Now, we know that we have some drugs which can be used as tocolytics, but unfortunately many drugs are not licensed for use in pregnancy, and of course there are no robust system to evaluate drug safety, and of course it's difficult to obtain real data on these drugs. For instance, if we look at least the European Union, we have only two licensed drugs in the European Union. One is atosiban, a oxytocin antagonist, and 2 or 3 beta-mimetic drugs, only 2 or 3 depending from the country. The unlicensed drugs are prostaglandin synthase inhibitors, calcium channel blocker, nitric oxide donors, and even magnesium sulfate, which is currently used in the United States because no one of these drugs has been approved by FDA in North America. So FDA has no real tocolytic drugs given in the pocket of obstetrician. Obstetrician can use only old drugs or, magnesium sulfate. However, it's quite clear magnesium sulfate is no more to be considered a tocolytic drug. It is being established by Cochrane, and it's been established by many editorials of expert people about. But it's only a dangerous drug, particularly at the amount of grams that is given to get a small tocolytic effect. The tocolytic effect is going to be active when we go over 36 grams a day. 36 grams a day. This is a very dangerous amount of drug. There is also another aspect we have to consider: the non-responders, the people that don't have any advantage of getting the tocolytic drugs, whatever is the drug, because of genetic variability. This applies, for instance, to beta mimetics, because of the presence of infection. So every time the patient is not answering the first 10 to 12 hours to a tocolytic drug, thinks that there can be an infection underlying, then of course we may have inappropriate dosage, antagonist effect, inappropriate route of administration, and the so-called therapeutic nihilism, which is the fact that sometimes doctors don't give the drug because they are fatalistic, or they think that the progression of labor is already going on and they don't want to give drugs. But I will comment in a moment. You see, for instance, this is genetic variance. Homozygoty for arginine 16 and codon 16 in substitution of the receptor, agonist receptor, change the capability to respond, for instance, to, let's say, to a beta agonist. And it has been clearly shown that we may have, a different genotypes on this receptor, and we may have 100% of tocolysis successful if we have this homozygote arginine 16, or only 50% or 75% if we are carrying another allele receptor binding protein. And I think also the other fact is that when we think that over 3 centimeters, if there is dilatation, we should not give any tocolytic drug, because now the labor is so advanced that there is no utility. This is another wrong axiom, because this study has been clearly demonstrated that even though I give treat patients which are over 3 centimeter dilatation, we can have better result compared to patients which are untreated over 30 centimeter of labor, particularly on development of respiratory distress syndrome and a long-term disability of the baby. So it's worthwhile anyhow, especially if we are less than 32 weeks, to be aggressive in trying to stop labor at least for a few hours. There is a big warning in the use of beta mimetics. It just came out recently, and the evaluation of butylene. We know that the beta mimetic drug reach the same concentration between the mother and the fetus, and we know that they activate and they unbalance the sympathetic parasympathetic tone, because they act on the beta-2 receptor, overstimulating these receptors. Now, it has been supposed that this drug may be linked, if given for a long time, to a functional behavioral teratogenesis, and in fact, there have been current data show that are more autistic babies which are born from women which have been treated with beta mimetic drugs. This is a very big warning, because for instance, we in Italy have used these drugs for many years, and of course this is a link which can be very important to consider. So there is a link between giving these drugs for especially more than 2 or 3 days